Yeah. Right.
Good morning, all. We are having this first plenary session. I welcome the dignitaries from abroad, Dr. Richard Quinton and Dr. Rudolph, who will be delivering the first plenary session. Hypogonadism as such is there is awareness because of the increasing prevalence of hypogonadism. In fact, in the United States, it's increasing to 40 to 50 million population. It is not only the hypogonadism, but the associated features, including the metabolic aberrations and the morbidity associated with it, makes it important to care for these patients. And we are going to hear what is from genes to care in male hypogonadism. I invite Richard Quinton, who is a consultant physician, Newcastle on Tyne, and he's a treasurer of EUMS, exam board member. He had got more than 200 publications, mainly in the area of hypogonadism. I invite you, sir, to give his lecture.
Many thanks for the invitation. It's a real pleasure to be here. It's a great pleasure also to meet Dr. Jayshree again. She almost came to train in Newcastle, but went to Cambridge instead, so I've almost forgiven her. Just to say that hypogonadism is just such an enormous... oh, this is the wrong presentation. This is tomorrow's one. Just to say that it's such an enormous area that really, in this talk here, I'm going to restrict myself to hypogonadotropic hypogonadism, the congenital form, because otherwise there's just simply too much to cover. Roughly speaking, you can break hypogonadism into two forms. To my patients, I explain it as light bulb broken or light switch off. So hypergonadotrophic hypogonadism, where your LH and FSH are raised, primary testicular dysfunction in men, so that's your light bulb is broken. Hypogonadotrophic hypogonadism, where you're missing the stimulation from the pituitary gland, that is where I say, no, there's nothing wrong with the light bulb, it's just the light switch is turned off. And the crucial thing about that form of hypogonadism is that fertility is potentially restorable. If you put back in the missing hormones, LH and FSH, you can restore fertility. Now, in practice, we can't use LH because, in fact, the half-life is too short. So we use something else which acts on the same receptor, which is HCG, which has a longer half-life. Although an HCG will induce the Leydig cells in the testes to secrete testosterone. For FSH, we have recombinant, but actually the menopausal version is much cheaper and just as good. Now, one interesting thing about the role of testosterone in the testes is that it's a paracrine role. We know that circulating testosterone in the blood circulates at sort of nanomolar concentrations, and that's sufficient for all the biological effects of testosterone on the body. But on the testes, so this is the action of testosterone on the Sertoli cells in the testes to facilitate sperm production, that's a paracrine role within the testes, inside the same gland. And for that role to be effective, you need micromolar concentrations of testosterone, 30 to 100 times higher than in the circulation. And that's why exogenous testosterone can never achieve these levels to facilitate sperm production. And indeed, that's why in a normal man, exogenous testosterone, such as androgen abuse, can actually make you infertile. So you may be boosting your circulating levels of testosterone with exogenous testosterone, but actually, by shutting down LH and FSH, you're then dropping your levels of intratesticular testosterone, paradoxically. So hypog, congenital hypog, probably about 1 in 4,000 men, maybe one in 10,000 women. In terms of the genetics, from the research perspective, it's incredibly interesting because there are at least 30 genes that have been discovered to date, and more genes being discovered by every year. And in fact, if you look at a pie chart, you see that each new gene that's discovered is responsible for around an extra 1 or 2% of the condition. So we're still looking at maybe 30–40% of the condition being actually unexplained genetically. And even for patients in whom we've found a gene mutation, that doesn't necessarily mean that you've actually explained the whole story, because in fact, for almost all of these genes, in the heterozygous state, that is insufficient to cause the condition. You need mutations. Historically, it was thought you needed maybe homozygous mutations, but increasingly, obviously, actually, it can be compound heterozygous. So 2 different mutations of the same gene, or even oligogenic, whereby there's heterozygous mutations in 2, 3, or even 4 different genes that are implicated in causing the condition. So and each of these genes has told us something new about human development, or about the neural network controlling secretion of gonadotropin-releasing hormone, which you think of as being the master hormone controlling human reproduction. Broadly speaking, there's 2 ways in which the genes can cause the condition. One is in the sense of a neurodevelopmental problem, and the other is in the sense of a neural network problem. So neurodevelopmental, so the genes for gonadotropin-releasing hormone, so the neurons that secrete gonadotropin-releasing hormone, GnRH, are unique in that they originate outside the central nervous system. They originate in the developing nose. And they migrate during the first trimester of fetal life along fibers of the olfactory nerve to get to the brain. And actually, the olfactory is also unique amongst cranial nerves, because it's the one cranial nerve where actually the axons grow from the periphery in rather than growing centrally out. And you see that any interruption in this pathway, anything that will interrupt migration of neurons, will also potentially cause anosmia, and hence around nearly half the patients with congenital hypog have got absent sense of smell, and that's known as Kalman syndrome. So the genetics really has told us a lot about, and also thinking about the neural network effects, we know that we've discovered through study of these patients other pathways, such as the kisspeptin pathway or neurokinin B pathway, pathways that actually determine pulsatile GnRH secretion. So, in fact, virtually all, okay, so I think I've got my slides now. Let's, right, go. No. Right, we're going to have to race a bit, sorry, some of this I've dealt with already. Okay, so we were talking about that, okay, yeah, fine. No, that one there with this, yeah, great. Okay, so we see here that, in fact, most of the feedback control of genetic secretion actually occurs at the top with the arcuate nucleus of the candy neurons there, secreting kisspeptin neuropeptide Y. So all the kind of homeostatic and internal and external environmental features that control secretion actually happen at the level of the arcuate nucleus, the candy neurons. And that's then fed back to the GnRH neurons secreting LH and FSH. So, And we assume really that it all begins in puberty, but actually it begins well before puberty. You see that the white line represents an overall integrated picture of the male reproductive axis. So it actually starts off at about age 7 weeks in utero, when actually the Leydig cells evolve and the HCG from the placenta drive testosterone secretion. And that's what makes us externally male. If that's missing, or if that's disrupted, then actually you will be externally female or a DSD, disorder of differentiation. The second phase, interesting, is called mini-puberty. So for about 8 weeks prepartum to around 6 months postpartum, the male reproductive axis is firing away almost as intensively as in an adult male. If that isn't working adequately, you may well be born with microphallus or cryptorchidism. Then during childhood, the axis quietens down. By the way, if you ever you may have seen male mini-puberty in your children. If you ever changed a little boy's nappy first thing in the morning, and he's got a little stiffy, little erection, that's male mini-puberty. That's not just because he's pleased to see mama. Then, of course, the axis reawakens at puberty, and if that doesn't happen, then you have features of absence of secondary sex characteristics. And then, of course, if you're presenting later in life, and the oldest man we've ever taken through puberty with a congenital problem was actually age 67. You have issues, and of course, he'd been seen by the bone doctors for osteoporosis. He'd been seen by the neurologists for myopathy. He'd been seen by the hematologists for anemia. And actually, all he needed was not zoledronic acid, not iron, and he just needed testosterone, and all those things kind of go away. And increasingly, we're seeing even men from the fertility clinic. So it's amazing how couples can be married for 2 to 3 years, even highly educated men and women, and one of the couple has never been through puberty, and no one's really recognized it. So this is the light bulb broken. Okay, and just how the the lights off hypogonadism, you have your genetic forms, your structural forms. I stress iron overload because actually the gonadotroph in the pituitary has got an iron transporter in the cell membrane. So it's the cell that's most affected by iron overload. Your corticotrophs, your thyrotrophs, they'll be okay. Gonadotrophs tend to be knocked out by iron overload. Traumatic brain injury, particularly military blast injury, knocks out your gonadotrophs. And then, of course, we have a functional reversible causes, constitutional in puberty, any kind of illness shuts the axis down. And actually, there's an epidemic of testosterone prescribed, particularly in the USA. It's coming here too. And these are not men who are hypogonadal. These are men who had a low testosterone because they're ill, non-gonadal illness. And actually, what you need to do is treat the non-gonadal illness, such as obesity or diabetes, and the axis will return to normal. And of course, anabolic steroids, androgen abuse in any gym these days. So, congenital form, you fail to initiate puberty, low testosterone, low or inappropriately normal LH and FSH, pituitary is otherwise normal, and it's a genetic or congenital defect of generic secretion or action. Many patients have non-reproductive phenotypes, such as anosmia, also clefting, deafness. So here are the genes as they were. I've stopped filling things in because I can't be bothered to fill in any more tiny little wedges to give an extra 1%. There's about another 10 since 2015. This is the migration of generated neurons from the nose into the hypothalamus. And we can see that the Kalman-type genes, neurodevelopmental, affecting that pathway. And then on the other side, these are the genes that affect how generated neurons are controlled or wired up. And of course, some genes can cause both a defect in either pathway, neurodevelopmental or neuroendocrine control. And remember, we need leptin. We need enough fat cells for our axis to work. So yeah, just interesting. One of these heterozygote genes, which we know that in combination with another mutation can cause the condition, every single, the one PROCAR2 L273R, every single person in the world who carries this mutation descends from a common ancestor. And that ancestor lived around 9,000 years ago. So we're talking the New Stone Age. That's when you could walk from Germany to Britain without getting your feet wet. That's when there were saber-toothed tigers and woolly rhinos and mammoths. So something's kept this gene, this mutation that affects reproduction, something has kept this gene in the human population for over 9,000 years. So there must be some kind of heterozygote advantage. I don't know. Just say there's also some genetic overlap between related syndromes, so charge syndrome, combined hormone deficiency, and also hypothalamic amenorrhea. We think of hypothalamic amenorrhea as being a purely environmental thing. You lose weight, exam stress, your periods shut down. But actually, why doesn't that happen to every woman? Why does that only happen to some women? The answer is it's probably because susceptible women are those that carry single copy, just one heterozygous mutation of a Kalman hypog type gene. So when do these patients get diagnosed in the Western world? This slide's from my old MD thesis, and you can see from that, that's when they should get diagnosed, probably, about age 14. And when did they actually get diagnosed from my thesis? Well, about 18 to 19 years. So that's your school days gone. Bye. And so this was data that's maybe 30 years old now. So when are they getting diagnosed and treated now? Well, actually, the same, 18 to 19 years. So that's your kind of school days gone. And partly the problem is the guidelines that the paediatricians put out. So this is some nonsense written by, actually he's the president of the College of Paediatricians in the UK now, sadly. So boys aged 15 or over with testes greater than 4 mil can be reassured that puberty is beginning. Rubbish. Those of the people about age 15 should be referred for further investigation. You wait till age 15? Are you insane? No, well, he's not insane. He's president of the Royal College of Paediatricians now. And so I'll give you Neil's story. Age 1, he underwent orchidopexy. Age 15 to 17, consulted a doctor many times lacking puberty. Always reassured. No concerns, just a late bloomer. Saw a paediatrician, received 6 monthly injections of Sustanon, some virilization, tested a bit bigger. He was discharged and told he was fine, forget it, it's all sorted now. Drifted through university, socially isolated, underachieved academically, came back at age 25, arrested early puberty, and actually a congenital hypog. And it's taken him almost 2 decades to kind of navigate the grief response and get over what he went through. So Amy's story, primary amenorrhea, age 13 and a half, seen by a pediatrician, otherwise healthy, signs of early puberty, linear growth preserved, but no growth spurt. All the hormones undetectable, but the respiratory hormones normal. She has no sense of smell. So she's told, as puberty has begun, the likeliest cause is constitutional delay. She needs a bone age, karyotype, picture MRI, pelvic ultrasound. This is all according to pediatric guidelines. And no treatment is required unless there's no progress after age 14. Again, this is all according to UK pediatric guidelines. Amy's kind of mum disagreed, and I think she was quite right. So congenital anosmia, primary amenorrhea, and hypog, that is Kalman syndrome until proven otherwise. And actually, contrary to what pediatricians say, the fact you've started puberty doesn't mean it's going to complete. A third of congenital hypog patients have a partial puberty. Amy's on the wrong clinical pathway. She's on the kind of delayed puberty query cause pathway, watch investigate. She should be on the totally flipping obvious hypogonadism pathway, induce puberty. And Amy's mum said, well, when should she have started estrogen? And I said, well, 2 years ago, when she was 11. Not wait until 14. And karyotype is not helpful. Bone age is one of the most useless pediatric tests I've ever encountered. Pelvic ultrasound is a catastrophe in hypogonadal girls because, of course, the uterus is so small you can't see it. And therefore, they say, oh, my goodness, I have no uterus. You have. It's just so small you can't see it. Never do an ultrasound until they've had at least 6 months of estrogen treatment first. So this is how pituitary MRI shows differently normal on the left and Kalman on the right. So your olfactory bulbs are absent and the sulci are absent. And these people who have been messed around with, like, presenting very, very late, they're very unhappy. So in a woman with hypog, their levels of social anxiety and stress are as bad as actually women with acromegaly or Cushing syndrome. Huge issues of body image and body shame, intimate relationship problems, depressive symptoms. Men, the psychology is even worse, thanks to the late diagnosis. Their distress is comparable to that of end-stage cardiac failure or COPD. 23% have never been in a relationship, about the same have never had sex. And there's a lot of anger directed at past doctors who told them they were late bloomers or gave false reassurance. So one of the things the pediatricians agonize about is how do you distinguish congenital hypoc-hypog from conjugal delay and delay puberty you really cause? And the answer is actually, it's really easy to look at the red flags. This could be our new prime minister. He wants to turn us back into the Soviet Union. And the red flags are historic indicators of absent mini puberty, microphallus, cryptorchidism, particularly bilateral, absent erection, body nappy change. Then your non-reproductive phenotypes associated with congenital hypoc-hypog, anosmia, deafness, cleft lip palate, syndactyly, clinodactyly, or family history. 5 to 10% of boys with bilateral cryptorchidism at 3 months will have congenital hypoc-hypog if you look for it. If you do blood tests during the mini-puberty window within 4 months of birth, you will identify congenital hypoc-hypog with 93% sensitivity and 100% specificity. If you treat these boys with FSH and HCG, you will induce testicular descent in 100% of CHH infants. So are we doing that? No. They're going straight from neonatologists to pediatric surgeons having their balls yanked down surgically. And I tell you, the testes of boys are small enough anyway. Testes of a boy with male hypogonadism, they're even tinier, very fiddly, very hard to bring down. The splenic cord is very short. You're trying to yank that down when it's very short. And also the scrotum's often hypoplastic. So there's quite a high failure rate for these procedures. A lot of testes are getting lost that way for something that could easily be done with a short course of injections. I think it's pretty shameful. So also, how do you manage these people who present late with pubertal delay? So first of all, in boys, it's all hypoc-hypog. So in women, primary and rear, about half a primary, light bulb broken, half a secondary, light switch off. In boys with absent puberty, it's always hypoc-hypog. And also the pediatricians say, well, you need to follow the normal tempo of puberty, 2 to 3 years. For boys, forget it. You know, age 19, you want to take through puberty in 3 years? No, they want to go through puberty in 1 year, fast. That's the thing that they're able to achieve them the best resolution, and that's what we do for them. So that's what you look like if you're at age 25, having not gone through puberty. And this is, of course, what we men all look like with our clothes off. This is as good as it gets without anabolic steroids. And testosterone will do all that. What it won't do is give you sperm. To give you sperm, you need FSH and micromolar, locally secreted paracrine testosterone. Girls, you're born with all your eggs good to go for the rest of your life. Us men, we need to go through 3 phases of development to get sperm. So your first phase is in 7 weeks gestation, your next phase is mini-puberty, and your final phase is puberty. So during mini-puberty, you've got some germ and Sertoli cell proliferation, but you don't get cell maturation or sperm production. And the reason is that until 5 years of age, the male Sertoli cell doesn't have angioreceptors, so they can't see testosterone, even though it's there. And in puberty, you're finally completing your process of germ and Sertoli cell maturation, forming seminiferous tubules and getting sperm. The Sertoli cells are known as the nurse cells of the testes, because each cell can nurse 4 germ cells into developing into sperm, and they need LH and FSH for that. The LH initiating local testosterone production from Leydig cells. And you think you put exogenous testosterone and you shut your whole axis down, you lose sperm. So I think I will need to skip through these. How to make sperm in these men? You can put them on a GnRH pump, pulses every 2 hours. Problem is that you have to keep this pump on for maybe up to 2 years. It's not available in many countries, and it's been made unnecessarily expensive. I can't believe how a decapeptide, 10 amino acids that's been known for 40, 50 years, can be made to cost $1,000 for 3 days' worth. In practice, we're using gonadotrophins, FSH, which induces Sertolian germ cell proliferation, and with testosterone produced locally, gets sperm production, and HCG. This is the expensive form we have in the UK now, recombinant. And that has a paracrine effect in the testes, inducing lady cells to make testosterone. And testosterone in the testes then causes Sertolian germ cell differentiation. So how likely do we get success? So first to say is in the men with congenital hypog, HCG alone is a complete waste of time. You might get a few sperm enough for ICSI. Men with congenital hypog, you need HCG and FSH. And even when you put HCG and FSH back in, the outcomes aren't great. So the men with a milder form of the condition, 80% get sperm. The men with a more severe form, which is about 2/3 of them, 50% get sperm. And if you're cryptorchid, really difficult. Not 30% get sperm. So how do you predict success? So obviously, if you acquire the condition post-puberty, so it's acquired hypog, like pituitary surgery, you do far better that way. And actually, these men, HCG alone might work. For the congenital, not being cryptorchid is very, very good. And obviously, having a higher baseline inhibin B level. There's also an in-treatment predictor, which is don't give blind FSH. Do some endocrinology. Achieve an FSH level greater than 4 units a litre. You get better outcomes that way. So why does this treatment take so long to work, or why is it not so successful? One possibility is absolute mini-puberty. And we can see that in Paris, they are actually beginning to identify these kids, these babies, give them gonadotrophins, bringing their testes down non-surgically, and that may give them a better outcome later in life. And also, when is the timing of gonadotrophins? So when do you put in your FSH treatment? And interestingly, it seems that if you introduce FSH first on its own, you're inducing germ and stem cell proliferation and causing some increased testicular enlargement, testicular maturing. And then when they go into combined treatment or GnRH pump, then you're inducing the differentiation. And actually, if you treat with FSH in these men with congenital conditions, small testes, before going into combined treatment, they have larger testes, more men with sperm, and higher maximum sperm counts. So logically, let them see FSH first to maximize the number of germ cells before you expose them to the differentiation signal. So how do you improve sperm outcomes in men with congenital hypog? Diagnose absent mini-puberty. Our pediatric colleagues have to take some ownership here and bring those testes down non-surgically. Genetic counseling, there's about a 5-10% risk of disease transmission. Appropriate sequence of gonadotropin initiation. HCG monotherapy is pointless in all but the mildest cases. Actively adjust your FSH dose. Adjust your HCG dose to achieve normal levels of serum hemoglobin, hematocrit, testosterone, and estradiol. If you give too much HCG, you can give them gynecomastia as their estradiol level rises. Don't give up until after 2 years have passed, but think about early ICSI if there's an older partner. Think about sperm banking. And in the offspring, screen the offspring for absent mini-puberty at 1 to 3 months to see if they inherited the condition. So conclusions, the patient's DNA has hugely advanced our knowledge of human development, but actually it's been a one-way thing. They've given us a lot. We haven't really given them back a lot. There hasn't been any really good improvements in patient care. And the bench to bedside really miracle hasn't yet happened. We doctors perform really poorly in managing delayed puberty, and the patients carry major psychological and psychosexual sequelae to this. We can achieve excellent diagnostics if we focus on diagnosing a mini-puberty in boys with cryptorchidism, micropenis, or deafness or clefting. And we can achieve better sperm outcomes with time, patience, and biological gonadotropin regimes. Thank you very much. I hope that wasn't too chaotic.
Thank you very much.
Thank you.